Sabah al-Khair. It's a real pleasure to be here and an honor. Thank you very much for this very kind invitation and for the generous introduction. When I was given this invitation about subclinical hypothyroidism, I had to think, what can I say about something that's been talked about for decades? What new thing can I bring to you that hasn't been said before? And I thought, well, rather than looking at it from an angle of what is new, maybe try and understand it from a slightly wider issue, taking a step back and thinking about subclinical hypothyroidism from a much wider angle. So hopefully over the next 25-30 minutes, I can try and compress a lot of information into that short period of time. Now, I can't promise that we'll have all the answers by the end of these 30 minutes. We'll probably end up with more questions, as it's usually the case in these scenarios. So again, taking a step back, I think the diagnosis, more than clinical, is biochemical. So looking at how thyroid functions have been evaluated. Initially, it used to be a clinical diagnosis. And then thyroid hormones were started to be measured. The first thyroid hormone was actually total T4 back in the 1960s. The first generation TSH assays were not available until 1975. And they were not as accurate as the assays, the third generation assays that we have now. And the accuracy was more around the upper end of normal. The lower end, below 1, you couldn't really know what you were measuring. So as time progressed, the second generation assay was more specific and could measure TSH until 0.1. And the more recent third generation assays can actually measure TSH below 0.1. So I think it's useful to know this. But what is important is that the upper limit hasn't really, the accuracy of the assay hasn't really changed a lot. So the prevalence shouldn't really have changed if everything was static. But there is some evidence that the prevalence may have actually reduced over time. And we'll try and look at that as we go on. So looking at age groups, this is mostly the US data. On the left is the Colorado study, and on the right is the Enhance study. Seems to be higher in women. Older people tend to get more diagnosed with subclinical hypothyroidism. And we'll try and again look at why that might be the case as you go on. And a lot of studies, anything between 5 to 10% is the accepted general prevalence of the condition. This is the global prevalence of hypothyroidism in general. And what you'll see is there's this big, huge gaps on the map. And particularly around this area, Bahrain, UAE, Kuwait, Iraq, there's not very much literature. I had a look before I came out here. And there is some literature, but that's mostly in either hospital outpatient clinics or from diabetes patients, but nothing at a population level that will tell us exactly whether the prevalence is about the same, higher, or lower. A lot of people that I've spoken to have said, oh, we think the prevalence is much higher. But I think there might be an ascertainment bias there, because if you see patients, especially for that condition, then you'll obviously see that condition to be much higher. So it's difficult to know exactly what the prevalence is. What we do know is that it's more common in older people, in women, in those with positive TPO antibodies, obesity, and we've just been talking about insulin resistance and metabolic syndrome. And therefore, we probably tend to see it more clustered in conditions associated with obesity, such as type 2 diabetes, such as polycystic ovarian syndrome, such as fatty liver disease. So it's very likely that it's not more common in these conditions, but it's the common factor is probably the metabolic syndrome and the obesity that is relevant. Areas that have a higher iodine intake tend to have higher TSH levels, and there are some really nice studies coming out from China where they used to have iodine deficiency before, and now they have moved to either iodine replete status or even iodine excess status, and they've nicely shown that the prevalence of high TSH has increased at least 2 or 3-fold from 2% to about 6 or 7% in the last 20 years or so. So we know that iodine has a role to play. Certain medications, and we know all this about amiodarone and lithium and so on. And what's also important, I think, and something that we don't really consider a lot when we look at blood results, is the time of the sample time, when the sample was taken. We know that TSH has this diurnal rhythm. It's highest early hours of the morning, probably highest about 3 in the morning, and lowest about 3 to 4 in the afternoon. So again, I'll share some data with you about the impact of time of sampling on the prevalence of subclinical hypothyroidism. Now, there are lots and lots of associations. These are relationships, such as with impaired quality of life or symptoms of hypothyroidism. There's this association with cognitive state and dementia, with higher cardiovascular risk and higher cardiovascular burden, progression to overt hypothyroidism, and also in pregnancy, in pregnant women, there are these associations with pregnancy-related outcomes and child-related outcomes, such as the IQ of the offspring and so on. So there are a lot of these associations, but again, we need to keep in mind that associations just imply a relationship between two variables. It doesn't necessarily tell you which one is the causal factor and which one's the outcome. It could, and we'll look at that again in a minute. So, is subclinical hypothyroidism a cause or just a bystander? We don't really have a lot of information. We'll try and cover some of the literature around this. So one possibility is that it's the thyroid or the slightly underactive thyroid that's causing the cardiovascular risk, as an example of the outcome. That is one possibility. The other possibility is what, if there are any statisticians around here, if you are a statistician, it's a strange place to be on a Thursday for you, but if you are, then you will know that this is called reverse causation, where we look at two variables and find an association, but it doesn't necessarily mean that the first is causing the second. It's equally likely that the second may be causing the first. Again, that's difficult to know with these kind of association studies. You need randomized controlled trials to prove causality. The third possibility is that both are related to something else. So as an example, as I've said before, obesity or metabolic syndrome could be related to both a higher TSH and to a higher cardiovascular risk. And therefore, when we don't account for the third factor, then you'll just notice the A to B or B to A relationship without taking the C into account. So I think there's these potential modifiable risk factors, there's the mediators, there's the bystanders, a lot of possible explanations for why we see this. And it's not as simple as saying it's A causing B, therefore if you treat A, B will get better. If that was the case, we would still not be standing here after 30 years discussing subclinical hypothyroidism. The other important thing is, and something that we've started realizing in the last 15, 16 years or so, is the high TSH in older people, particularly the oldest old, is a very special subgroup of people, the 80-year-olds and the 85-year-olds. The reason for that was this paper, which on the left of your screen was published in JAMA from the Leiden group. So they looked at 85-year-olds and they measured the thyroid function at baseline and followed them up over the next 4 years. They had TSH and free T4 at baseline. And what they found is people with the highest TSH actually survived the longest. And people with the most normal TSH had less survival, suggesting that a higher TSH was associated with higher longevity, which is slightly unusual and different to what you would normally have assumed. You would have thought if it's underactive thyroid, they would have a higher cardiovascular risk, they'll all have much higher disease burden, therefore their survival would be lower. But that wasn't the case. This kind of set the cat among the pigeons, and people started questioning whether the previously held belief that treating all subclinical hypothyroidism was actually a good thing, particularly in this select age group of the oldest old. We tried to see whether we had a similar relationship in our cohort in Newcastle, so we had slightly higher numbers, and again on the right-hand side of the screen you will see the TSH first and then the free T4, and although it didn't reach statistical significance, but there was this trend that higher TSH in the 85-year-olds was associated with better survival. So again, I think it kind of suggests that a higher TSH in somebody who's 85 or 86 may not be detrimental to them. And opposite to that, free T4, again there was a trend that higher free T4 levels were associated with worse prognosis. Again, it didn't reach statistical significance, but once again, kind of shows that in that age group of people, higher free T4 levels may not be a good thing, which again brings into question whether, trying to aim for a TSH that is 1 and a free T4 that's 20 in picomoles per liter in somebody who's 80 or 85 is the right strategy or not. Again, we don't know the answer. So as I said, the prevalence of subclinical hypothyroidism over the years seems to have decreased. And this is a paper from Norway that looked at the prevalence of untreated overt hypothyroidism, which is the top, and the subclinical hypothyroidism, which is the bottom. And you'll see that in men and women, across all age groups, there is this almost halving of the prevalence in Norway. And that is because the treatment with thyroxine has doubled in that time period. So we are picking up lots more marginally raised TSH early, and we are treating them a lot more, and therefore we are picking up less people with high TSH, at least in Norway, is what the authors conclude from this study. And that may be one explanation as to why the prescriptions for thyroxine have been increasing over the years. Now, this is some data from general practitioners in the UK. One of my colleagues in Cardiff, Peter Taylor, did this analysis looking at the something called the General Practitioner Research Database, and what they showed is that across 2000 till 2009, the prescription rates seemed to go up for thyroxine, whereas the TSH level at which thyroxine was being started seemed to be lower and lower and lower every year. So starting out about an average of 8.7, 8.8 back in the early 2000s, down to about 7.8, 7.9 by 2009. And it's likely that it's probably even lower as we speak, maybe 6 or 7. So there's all these things. So in practice, I think a lot of people are being treated. And as I said, this is data both from the US and the UK on the left-hand side. In the US, thyroxine was the 4th most prescribed drug and was at least in 2014 the top most prescribed drug. In the UK, it was the 3rd most prescribed drug back in 2014, and briefly a couple of years ago it was the 2nd most prescribed drug. So it is having a huge impact, and the large majority of people who are being treated are not overt hypothyroid patients. They are not people who have had thyroidectomies or thyroid cancers. They are people with subclinical hypothyroidism, I think. As I said at the beginning, it's not a new topic of conversation or debate. It's been discussed and debated over many years, and to highlight this, I've shown you snippets of a conversation 2 sets of experts had back in 2004. where one group at the top argued that it is mild, subclinical hypothyroidism is mild thyroid failure and should be treated, whereas the group at the bottom said it isn't always necessary. And I think that debate has almost continued over the years, and hopefully by the end of this topic today, we'll come to the view that it's a little bit more nuanced than just saying that everyone should be treated versus everyone shouldn't be treated. I think we will need to identify the group who are more likely to benefit from treatment rather than having a one-size-fits-all approach. So it has been a controversial topic. And one of the things that has been added to this controversy was a clinical practice guideline that was published in the British Medical Journal about 3 or 4 years ago. And what is really interesting, if you look at the authors in that group, and I've been in the field of thyroid disease for a good number of years, and I think I know a lot of good thyroidologists around the world, including here in Bahrain. I can't identify any single endocrinologist in that author group. This was a guideline that was written by public health specialists, by general practitioners, statisticians, and patient groups, without any meaningful contribution by endocrinologists. And their interpretation of the data can be seen in what they conclude, which is basically that no one with a TSH less than 20 should be treated. And I'm not entirely sure where this figure of 20 comes from. Where does this TSH cutoff of 20 comes from? It's quite a question that hasn't been answered yet. So it did lead to a lot of controversy. It generated a lot of responses to the BMJ article. Many thyroidologists, including in the US, in the UK, and here in the Middle East that I've spoken to, do not particularly agree with this. Imagine if you have a 35-year-old lady who has a TSH of 19.5 and is feeling extremely fatigued. Would you not give her a trial of thyroxine? So if you listen to, or if you follow these guidelines, you shouldn't. And the reason why they say that is the case is because of randomized controlled data and a meta-analysis of that data. But the bulk of that randomized controlled trials come from older patients and not necessarily younger patients. So I think we have to keep such things in mind, that guidelines are there to guide us and not to dictate or rule our clinical practice. We need to question some of these guidelines, and we need to follow what is good and what we think is good, and maybe not follow to the letter what may not be that evidence-based. So looking at younger people, as talked about, this was a trial I was involved with as part of my PhD, where we recruited 100 patients, younger patients with subclinical hypothyroidism, and randomized them to thyroxine. And one of the outcomes we assessed was quality of life and symptoms. And as you'll see on the right-hand side of your screen, a number of p-values did improve, suggesting that in younger people, treatment may be beneficial. So this was back in 2007. Now, what about older people? The biggest trial to date has been the TRUST trial, which was across most of Europe, initiated by people in Switzerland and led by a geriatrician in Glasgow, where they recruited people above the age of 65 and with subclinical hypothyroidism, and randomized them to either levothyroxine or placebo and followed them up for 12 months. What is important to know about this trial is that originally this trial was designed to assess cardiovascular outcomes. And for that, they needed to recruit 3,000 participants. They couldn't, so they had to redesign the trial and change the primary outcome to quality of life 2.5 to 3 years into the trial running. One of the other important things to remember about this trial is that these patients were identified from primary care. And as you can imagine, a patient who goes to see their GP, say complaining of fatigue or weight gain or slower memory, and the GP says, you can either go into this trial where you might get thyroxine or placebo for 12 months, or I can give you thyroxine now. It's very likely that there will be a selection bias. The people with the less symptoms will probably say yes to taking part in the trial because they have a 50-50 chance of getting treatment, whereas people with a higher symptom score or impaired quality of life will probably say, I'd rather try treatment rather than try, risk going on to placebo. So the kind of patients they recruited were patients who didn't really have a higher disease burden or impairment in their quality of life. So if you try and treat somebody who doesn't have impaired quality of life, looking for improvement in their quality of life, you're likely to end up with a negative trial. And that's exactly what happened. So I think we still don't know the answer whether in older people, if you treat somebody with a lot of symptoms, whether it's associated with any benefit or, for that matter, any adverse outcomes. We still don't know the answer. But I think what we do know is just treating people with abnormal biochemistry isn't beneficial. I think what we can take from this trial. As you can see, none of the p-values for tiredness or quality of life at 12 months or at an extended period of time were significant in this very large trial. I must say they had 700 plus participants in this multi-center prospective randomized double-blind study. The other group that was looked at, so part of these were from the TRUST trial, and there's a separate trial called EMO, and the authors got together because they had a similar protocol, and they combined the results to add power and published the results together. And this was the 80 years or older patients with subclinical hypothyroidism, and similarly, again, no benefit in either quality of life improvement or tiredness was seen at 12 months or at 18 months in this group of patients. What about people with higher cardiovascular risk? So this was a trial we published 2020, about 3 years ago, nearly 2.5, 3 years ago now, where we recruited patients with acute myocardial infarction who had subclinical hypothyroidism, and we randomized them to either thyroxine or placebo and assessed their left ventricular function using cardiac MR, which I'm sure you all know is a very sensitive and accurate marker of left ventricular function, but particularly systolic function. But what we found is that it didn't really have any beneficial effect. There was no significant improvement in left ventricular function at 12 months after being randomized to either thyroxine or placebo in this group of patients. So in an acute situation, when you start thyroxine, now as part of this trial, we didn't start the thyroxine straight away. We started about 7 to 10 days later after repeat TSH was also elevated. So we didn't just rely on one raised TSH. What about pregnancy? So this was a trial by John Lazarus called the CAT study, where they looked at people with women in the, if I remember correctly, 16th week of pregnancy with raised TSH, and randomized them to either thyroxine or placebo, looking at IQ in the offspring, and it didn't really show any benefit in there. One of the criticism of this study was 16 weeks might be too late, and maybe earlier intervention may be beneficial. So Brian Casey in the US came up with this much larger study. But again, the problem with pregnancy is that by the time it's confirmed and you do the test and recruit people, it's already at least 8 weeks or so before they can be recruited. And so in the Casey study, it was slightly earlier. On average, I think it was about 9 to 10 weeks by the time they were randomized, and again, didn't really show any benefit on any of the outcomes that they assessed in this group. The question remains whether if we were to intervene earlier than 8 weeks, because as I'm sure you all recognize, the bulk of the neuronal development in the fetus is in the first few weeks, particularly, and maybe 9-10 weeks is late, possibly. But the problem is, it's at least 4 weeks before we know that somebody may be pregnant or not. So it's going to be a very difficult area to be able to get a clear-cut answer anytime soon. One of the reasons for the BMJ clinical practice guidelines was this meta-analysis that was published in JAMA in 2018, where they looked at various studies. Now, what they did is a lot of the studies use various tools to determine quality of life. So some use SF-36, some use thyroid disease-specific questionnaires, some others use a general health quality of life, but they kind of pooled everything together using standardization and showed that in terms of quality of life at least, treatment may not be beneficial, and that is one of the reasons given by the authors of the clinical practice guidelines about not treating subclinical hypo. But one of the problems is that majority of these studies, the TSH of the included individuals was below 10. So again, I'm not entirely sure where this cutoff of 20 has come from, certainly not from the trials that have been assessed so far. The other question, I suppose, is what happens to TSH if you don't treat it? And if you forget the effect of treatment, if you look at the placebo arm in a lot of these, so I've picked out 3 randomized controlled trials here. So if you look at the one on the left, that's from the TRUST study, the TSH at baseline was about 6.1, 6.2. At 12 months, and even at extended follow-up, you'll see there's this reduction in the thyroxine group, as you'd expect and hope with thyroxine. But also in the placebo group, it didn't stay static. It didn't stay the same. It didn't go higher. It actually tended to be lower as time went on. Again, statisticians have a term for this. They call it regression to the mean. That's certainly one possibility. If you look at the group on the right-hand side of your screen at the top, roughly 50% of people at the end of 12 months of treatment with placebo had normalized thyroid function, and similarly, the trial at the bottom, at 6 months, 33% had normalized their TSH, and at 12 months, almost 50% had normalized their TSH whilst being on placebo. So there's this other question mark as to what happens if you don't treat and just follow people up. The evidence suggests that at least half the number of people will have normal thyroid function at some point. Now, we don't have data over years or decades to say what will eventually happen to these people. We know that certain percentage will progress to overt hypothyroidism, and we know certain risk factors for that. The higher the TSH level, positive TPO antibodies, and so on, that are a higher risk. But at least over 12 to 18 months, we don't really know who is likely to be normal, and I say normal in inverted commas, versus having a raised TSH. The ATA came out with their guidelines about management of thyroid disease, including subclinical hypothyroidism, back in 2012. That's 10 or 11 years ago. There's been a lot of literature since then. They haven't really come out with any up-to-date guidelines on this topic since then. And if you see, what they do say is that people with a TSH more than 10 should be considered for treatment. And treatment should be based on an individualized score for the patients, not as a number. It's not as if you have one number and you treat those people, and you have a different number, you wouldn't treat those people. So I think you have to take the overall circumstances into account.
Doctor, you have 2 minutes left.
Thank you. The ETA came up with their guidelines We're back. So the ETA came up with their guidelines. They looked at the age. They looked at the age, they looked at the TSH level, and suggested that we kind of look at the age of the participant, the TSH level of the patient, and also the number of symptoms and vascular and comorbidities of the patient into account before deciding on treatment. So I think there's a much more better approach in managing these patients. And again, people have suggested having a grading of subclinical hypothyroidism, whether it's a grade 1 or a grade 2, and again suggestive that grade 2 are more likely to benefit from treatment. We looked at who might be treating, and we find that across the world there are certain regions where treatment is much more likely, and in other parts it's less likely. So coming to the end, I think anybody with TSH greater than 10, all adults and pregnancy, we should consider treatment. I'm not saying we should treat them. I think we should certainly consider treatment in that group. In those whose TSH is less than 10, I think the age is important, and the symptoms or the degree of symptoms are important. And pregnancy, particularly with positive TPO antibodies, is another important factor to take into account. So, to summarize, it's a common condition and frequently treated. The evidence for benefit of treatment is there for some groups, but not necessarily for all. A number of factors at an individual patient level should be taken into consideration, such as the age, such as the BMI, such as the comorbidities, and consideration should be made for treating the other comorbidities rather than focusing on the TSH alone. And again, I think we lack high quality evidence to prove one thing or the other, so it's an open field. Thank you very much.